All right. Standard of care, hygiene standard of care. Wonder how many people have an actual written standard of care. Anybody? Anybody have a written standard of care?
What page should they be looking at, Paula?
Oh, let's see.
We're going to start on page
58.
Yeah.
58.
Now, we skipped over the pages with the emotional exam, and we talked about that in SWAT, where there's a form. There was before page 58, where you can actually document and write down the emotional exam from the patient. We can come back and talk about that and even practice it some. But I think what we've got, standard of care and fee analysis and Perio percentage are just big topics we should be talking about. So you want to, and this is just a sample. I mean, I don't know. Debbie, do y'all have a written standard of care?
We do. Yes.
Do you?
It pretty much breaks down every appointment that a hygienist would do. From child new patient or child patient, adult patient, teen, root debridement therapy, new patient, sedation patient.
Oh, wow. Yeah. Okay. So it's probably more detailed than this.
Yes.
Yeah. Like I said, this is a sample. And some people are putting in, like, put sunglasses on the patient. I know I had my hygiene visit this week and they put sunglasses on me, which is part of standard of care now. Right?
Pre-rinse.
Pre-rinse.
Yeah.
That's standard of care now.
And I think from this comes the scheduling matrix too. I think they're intertwined that way. And also your periotyping, it should be in here. And we need to we'll get into some more of that. But this is just an example of how you could start to do this. And if you don't have one, especially if you're new, you can feel lost.
Yeah, for sure. I mean, there's a lot of practices you have temp hygienists come in and they don't know how you do things.
Yeah. I mean, I think almost all of my practices do 4 bite wings, first PA, additional PA. We're billing out 6 x-rays annually. And if you're not doing that, you're missing some diagnosis and you're missing the production that's needed as well.
And what was the deal with PA codes this year, Eric? Something changed.
Yeah, they're not, even like I had an office, they thought that meant to switch, and so they switched and they got denials from Delta. So it seems a bit, I don't know if it's cumbersome or what is the right word, but it's not work. Just keep doing what you're doing. And then as insurances, you'll start to see them change the code from 0220 to the new code if that's what they seem like they want to do. So right now, we're just doing the same thing. Let the insurances change when they're ready. They'll start dictating to us what we should change. Very confusing though.
So let's put standard of care on our discussion topic we're going to have here in just a little bit.
Okay.
I'd love to hear more comments on that. Debbie, anything you want to add to this?
We've actually even got, what our oral hygiene tools are that we would recommend to patients. Okay. Yeah. Down there. Yeah.
Yeah. You'd add all these things to make sure that you're utilizing them in the conversation. And again, the natural law of the herd. I have a lot of my patients who use this, whatever that product is, to help with whatever they're dealing with. It could be, water pick, obviously Sonicare, Oral-B. Yep. Any of these will work. Everybody seems to have Breath RX product. Everybody seems to have their own thing they like, they use. You need to know what those are and probably have them displayed, right, Paula?
Yeah. Yeah, I mean, when we display, I like to have like one item, not just like you stock everything there and it can start looking messy. So you have one item and a benefit statement about that item. So what do I mean by that? A benefit statement? Like, what's a benefit statement for in-office whitening? You know, wedding this weekend? Need to whiten fast? You know, something like that. Or
We bring good things to white.
we that's good. That's good. You know, alcohol. I like putting the question in. You know, does the alcohol mouthwash dry out your mouth? Do alcohol mouthwashes cause dry mouth? I mean, something like that is short to the point where they get, oh, I've never thought about that before.
Yeah. I love Closis, Clossys. If people aren't familiar with that, it's a great product to have
We used
for
to
an
sell
oral
that.
rinse. Yeah, amazing. It's like magic for some people.
Yeah.
Yeah, you
So
got to
having
have all these things. You got to have it done. And then your scheduling matrix is like how you schedule, for admin people, how you schedule every type of appointment. So if you have, let's go back up here, recall a new patient, then you have down here Perio, Perio type 1, 2, and 3, and you have how you schedule it. That's got to be put in there too.
Mhm. Number of visits they need.
Mm-hmm.
Yeah.
Yep. Yep.
And how to code that out for the admin team.
Mm-hmm.
I may have somewhere in my files the Perio case 1, 2, and 3, if we want that written out. Some samples or something, but
Yeah.
and I think that one of the big challenges is like I said, coding that on the admin side. What codes are we using? Making sure we're coding that properly.
Yeah, it can get confusing really quickly if everybody's doing something different and you've got multiple hygienists in the department doing things
Yeah.
on their own. It's all got to be the same. Yeah. Yeah.
So, Eric, do you want to talk about fees?
Sure. Yeah. Let's keep it up here then. So I look, every area, of course, demographic is different. I'm not a huge, hey, participate in insurance guy. That's just not my cup of tea. It's not how I grew up. I think most of the practices that are here today would agree with that. I think Delta is the big bad wolf in the room, as far as insurance goes, and how do you get out of that is a challenge for some people. And I've helped offices do that. But, we want to be able to charge everybody the same rate, to be fair, and whatever their insurance pays in reimbursement for that is great. That's for their benefit. And we got to know how to talk about that. But I don't think we can feel guilty. How about I stop sharing, Paula? Well, no, actually I want to show something, so I won't. But, I don't want us to feel guilty about our fees, first of all. And then we have, Paula, I'm always emailing Paula, hey, can we get an NDAS for this zip code? So Paula can help you with a fee analysis. But I think that with COVID, even especially, people are getting hesitant about raising their fees, Paula. And we have to make sure that we're still within a window, a normal window, what fees ought to be. And all too often, I hear offices, they just don't raise fees for years, right?
I know, and I think I know I'm on the fence on the patient side. If I put on my patient hat, do I have a patient hat over here? I don't know, but if I put on my patient hat, I don't want to raise fees because COVID's been a hard year. But I put on my practice hat. COVID's been a hard year for the practice with all the PPE that we've had to buy.
Mm-hmm.
And are we going to be viable if we don't raise our fees? I don't know. I mean, Debbie, what are y'all thinking about?
We actually haven't done a fee increase this year. We haven't, to my knowledge, we haven't talked about it yet.
Mm-hmm.
But usually the first of the year, we change
Yeah.
our fees.
Yeah. So, what's everybody else doing about fees? I mean, we could save that for our discussion, but
We did it right when we got back because our costs had gone up so much that it just made sense to.
And we
Like
sent a letter to our patients, letting them know.
Yeah. I mean, it's the same as like if you were building a house the year before or this year, your house costs would be way higher because the supplies are way higher.
oh yeah,
So To me, it just makes sense.
Yeah, it absolutely does. And, you can let your patients know, but I think sometimes not saying a whole lot until they
Yeah.
ask. I mean, there's some fee verbal skills. I mean, one is, it's objection formula. I hear you. I hear what you're saying. It's been a crazy year for everybody. Did you know? Most patients want us to stay safe here. Is that something you want us to do? Do you want us to stay safe for ourselves and also protect you when you come in? The extra things that we've had to do this year have cost more money to stay safe. And maybe have a list ready of those things.
And I don't think, I mean, everybody free to choose their own. I'm not a big proponent of trying to add a PPE fee. I think it
No.
was in June, I saw a Facebook post from a patient. And he's like, can you believe my doctor just charged me $20 more to come in
Yeah.
and see him? That's just going to cause people not to come to you. So it'd be safer just to increase all your fees a little bit, right? To cover that new cost than it would be to try to add on a fee. That never seems to go well.
And if somebody is complaining about that, you say, I realize you weren't prepared for that. So why not today? We charge you the fee that you were prepared for. Same as last time. And then next time when you come in, you'll be ready for that. So it's always a good place to make a, kind of a meet in the middle. Kind of, is that what you guys do, Katie Lynn? Kind of say, you weren't prepared.
Well, I mean, we don't really talk about our fees going up. I believe I just started in June 1st, and I want to say sometime in July is when we raised our fees. Some a little more than others. And we don't get a whole lot of resistance. It just
Yeah.
goes because we're not a contract provider anyways. So
Yeah.
people know they're going to have an out of pocket. But there hasn't been any pushback on it.
Yeah.
That's good.
Yeah.
Most of the time, if you're providing that Ritz-Carlton service, right, Dr. Allgood, patients aren't going to complain a whole lot. They might mention it, but it doesn't mean they won't pay it and they're upset. That's where we have to keep a 10 on our head. Tell us, Dr. Allgood, you had a fee-for-service practice. How did you handle, you're on mute, by the way. How did you handle fee increase conversations with your patient if it ever came up?
I don't know that we ever worried too much about handling the conversation with the patients with the fee increase. It's we didn't have that many fee increases as we went along because we had our fees up in pretty good shape anyway.
Yeah.
And that so they may have added a little bit more on now because of the COVID things, but and I mean, we just let the patients know what the fees were, and very rarely were there any complaints. We let them know ahead of time.
Yeah.
And it's one of the things, especially the way we handle new patients, that we're working up full treatment plans on just about every one of them. We did a lot of high fear patients, and so. And one thing, after we went through all the Dawson and Pankey and all, just about every new patient came through the doctor's side and through the consult room. And so you find out the patient's needs and develop the treatment plan and go over the fees with them. And when you provide quality service, there's very little complaint about fees. And if they think they're not getting quality service, they're going to complain about it.
If you're, I have a little conversation I do with people on this quote right here. I think I came up with this. I'm not sure that I've heard it anywhere else. But price is the number one comparison until value is perceived. Perceived is the key word there. Price will be the number one comparison with your patients until value is perceived.
Well, that's why you go through and work on the Ritz-Carlton quality perception with your verbal skills.
Right.
Yeah, the whole works. It makes a huge difference.
I mean, can you imagine somebody going into Starbucks and saying, how come your coffee is more expensive than the gas station down the street?
Mhm.
Good point.
They would not do that. Why would they not do that? Because there is a huge difference in perception of the gas station down the street and the Starbucks location. So you think about that.
It's the experience that
Yes.
they're having.
A couple different ways to say that is value equals benefits minus the cost, right? That's a Google definition, right? But the other is looking at it like if your relationship with your patient is built upon money or cheap prices, when those prices go up, the relationship changes.
Mm-hmm.
So if you're solely focused on, hey, I just want to be a network with insurance, I just want to, again, probably approval addicted, and I want to lower my fees to get people so they won't leave. I was asking a dentist the other day who's in network with some. I said, why do dentists do you think be in network to begin with? And he said, so that patients won't leave. And I hadn't, I was like, oh, well, no, actually it's a marketing tool, right? You're in network and they're supposed to be sending patients to you, but there's so many dentists in network that you get lost in the list now. And so if you were paying that write-off rate to that insurance company as a marketing company, would you think you're getting a fair deal? How many new patients are they sending you per your cost every month? Every more patients you get, the more you're writing off. It's a bad deal. It's like buying mortgage life insurance. The value of your mortgage is going down, but you keep paying the same or more as you get older on that mortgage. And so the value of the insurance plan loses while you pay more. It's kind of the same thing with insurance is the more patients they send you, the more you're writing off. The value of that being in network actually starts to deplete. It depletes. It goes the wrong direction. They're not more valuable. And then these dentists will say, now I got all these patients. Now I want to get out of network. Well, if you've built your relationship with them on the fact that it's based upon money, it's like, the person who's looking for a spouse because they're rich. Well, if they ever lose their money, consider it a divorce notice, right? So the same thing will happen if your practice is built solely on that and not a Ritz-Carlton and not a relationship focus and not comprehensive, and you don't look like Starbucks compared to a gas station. You've got to make sure that they would expect to pay that based upon the experience they're having with your practice.
Yeah,
That's
that's
one thing that you have to provide that quality experience. You can't have a good fee without a good experience for them.
That's right.
That's why we bake cookies, right?
That's right. That's right. The cookies are a big help. We used to do that too. And you're building your facility. There's a 360-degree experience that we're talking about. The Starbucks building looks different than the gas station. It smells different. It's decorated different on the inside. The service of the personnel, their verbal skills, the way they talk to you is different. It's just what the variety of what they offer. Now, I know the gas stations are offering cappuccinos now and all these, but you have to fix it yourself, right? And they don't remember your name. And
Gasachinos, yeah.
Yeah, Gasachinos. There you go. So, I mean, we could go on and on about the differences, and really the hygiene visit, you've got to show a difference in your hygiene visit versus an Aspen or a clinic. It's got to be different, and what's different about it. That's a good conversation to have. I wanted to ask if you have a new patient package fee in your practice. So in other words, when you're on the phone and the patient's asking how much is it going to cost for this visit, do you have a package fee? Does anybody offer a package? You know what I'm talking about? No? Okay. So one thing that really helped on the phone with all we were going to be doing in the visit is to include it all in a one price. And this can help eliminate the objection for x-rays. Oh, look, we have a kitty. Can help eliminate the objection for x-rays. and the prices, and well, I don't want a comp exam, or I don't want x-rays, or I don't want this, I don't want that. And you say, you know what, it's all included.
Yeah.
It's all
Yeah.
included.
We have you come in, and that's for patients who are asking how much it's going to be. Sometimes, remember, they don't know what to ask, but for Kaylin, other administrators, it's, you know what, you come in here, we take care of everything for you. It's almost like a sedation visit. A full mouth sedation case, you're not going to shake the patient, wake them up and say, hey, just so you know, it's going to be $1,500 more. You need a root canal on number 2. You just do it, and you hope that your price has that built in. And the same thing for a new patient exam. It's already a loss leader, and you're never gonna get $500 an hour on a new patient. It's just not gonna work that way. So you got to figure out how to create that value, and show them, hey, you get all of this. How we start with all of our patients. You get everything we do every single time you have a new patient. We do all of these things, and you want to make sure they understand that they're not getting shortchanged.
And all included, let them know, because I mean, this is the tough part about the new patient phone call is it costs more to come in typically as a new patient than a regular hygiene visit. And it's like, welcome to our practice, yeah, our regular visit is this much, and because you're a new patient, it's going to be this much. And so we want to think about that package fee, $199, and there's psychology and pricing, by the way. The odd numbers go over better than the even numbers. In other words, $199 is better than $200. That's why you see in the stores, they're all got 99 cents, $1.99, $2.99, whatever, because there's that psychology in the pricing. So you say, you know what, our new patient visit is $199 or $2.99 or whatever you want to make it, and that includes everything. It includes this, and that is really a $400 value. So you're building a little bit of value in why that price is what it is by telling them this is, if we were to do this a la carte, it would really be like $400, something like that. So that gives them a sense of the deal they're getting. And also, another thing, when we're talking about raising prices, raising fees, looking at the hygiene as a package, as far as like your prophy exam bite wings, what's your current fee? And I know a lot of people go in and just raise everything 3% or something like that. Eric, is that right?
Yeah, cost of living.
Well, look at what your hygiene package fee is now, prophy exam bite wing. And then when you raise that fee 3%, what is your prophy exam bite wing going to be then? If it went up like a whole lot, you might want to rethink that.
Yeah, you need to make sure that hygiene visit, when you increase it, only goes up that $10 to $15 range, probably total, maybe $20. That's about.
And if you're going to cross the psychological barrier, like if you're at $275 and then you raise your fees and it's going to put you at $310, you just crossed from 200 to 300, and that's going to be a bigger aha to your patient, rather than if you stayed under. You still raise your fee, but you're under that 200, under the $300 mark. Is that making sense?
Yeah, absolutely. And so I want to show this to you guys because this is the tracker. This is a yearly summary. This is the whole practice. This is January through December hygiene department. This is a practice that doesn't have a lot of patients, but they do a very effective job at a lot of things. And I wanted to show you an example of them. So first of all, what we're talking about is production per patient. And remember we said earlier, like 125, maybe to 175 per patient. Their per patient value right now is $246 in hygiene.
That's fantastic.
That's really good. And their hourly is $233, which means they have a very low cancellation rate. You can see they only had 1 month where they were in double digits for open hours in hygiene. And they have about 1.5 hygienists, about 6 days a week of hygiene. So remember, it's a smaller department, but they're very effective. What I'm most proud of them for is their Perio percentage. So Debbie, I mean, apples to apples here. What should we be thinking in terms of Perio percentage for a practice? When we think, what should your Perio percentage be? What crosses your mind? Do you have any ideas, or do you keep track of that?
Well, if 80% of the population has some form of gum disease, then
Yep.
I'm thinking you should be at least 60, 70, 80%.
So, and here's the next statistic. Half the people don't go to the dentist. Usually the
Yeah.
unhealthy half, right?
Mm-hmm.
So this practice is phenomenal at 53% perio,
Yeah.
because if you can get
That's
above
good.
40% perio, you're doing a pretty good job. 80% of people have some, and that includes gingivitis too. So we're not calculating
Yeah.
gingivitis here too. So they have a lot of people on prophy 3 months. So if you were to include those, you'd probably be closer to that 70% mark. Their patients they see over 6 months isn't, let's see, 1, 2, 3, 4, 5, 6. So 788 patients in a 6-month rate. And so you can tell they don't have a lot of patients in their practice, but the ones they do a really good job at maintaining this. In comparison, okay, here's a busy practice. Now they kill it in hygiene. They have huge numbers in hygiene. They see a ton of patients. They're off the charts, right? And their perio is, I mean, let's look at this number right here. Their perio is at
Yeah.
8%.
Wow.
Okay.
Yeah. Wow.
So think about the potential that's there in that hygiene department to grow. Now, asterisk here, they see a lot of their new patients in hygiene. And when you see a lot of new patients, it has a tendency to change this number. So, 150, so 70 new patients in here, not too bad considering it's I think they have three and a half hygienists per week, kind of similar to you guys, Debbie, actually. I don't know if it's the same as Mount Pleasant as far as number of days a week, but it's one of those larger departments. But you can see what they can do when they're working on all cylinders. And I think here's the thing: they're almost too busy to convert it to perio. They've seen so many patients for so many years that they're afraid to stop doing the super prophy and convert them into perio. Whereas the other practice, even though smaller, so I wanted to show you the production per visit. Sorry, that was the whole point. So look at 173 and 161. And the only reason I can figure out is this number right here, perio.
Yeah.
So you can see how direct that influence is on, you want to be efficient and effective with your time, perio. Not only does it help that number, the reason that is it also keeps cancellations down. Why? Because it's not just a prophy anymore. It's not just a cleaning. So when the perio increases, the cancellations decrease. You guys all see that?
That's awesome. Those are great examples. I mean, it just really puts it real clear.
So I would challenge you. Here's my challenge for you guys now is, do you know your perio percentage? Okay. And what is healthy? I would say it's got to be north of 30%. Okay. That would be a pretty normal number. Now, if you saw a ton of kids and a ton of new patients in your schedule, it's going to be harder to do. But it should be north of 30%, 35. I mean, like I want it in that range. I also have a practice in San Jose that they just have a super healthy patient base. Like they really struggle. They are perio to the max. They do modular therapy. They diagnose, they do everything they're supposed to do. And they're right around 10% perio. And the reason for that is their patients grew up in a very affluent area, going to the dentist all the time, fluoride in the water, you name it. They've had access to it. And so what that has done is help them realize we're not going to be at that 30 to 35% range. We got to do other things to maintain our numbers. So does anybody not know their perio percentage, their personal perio percentage? Raise your hand if you don't know it. Okay. All right. You don't know it. All right. Okay. So if you're using my tracker, we will know it. If you're using some sort of tracker system, you will know it. Okay. So whether that's a dashboard online or an Excel spreadsheet like this, you'll know it. If you want to get a feel for it, you can audit your week. You can choose a week, go in, count how many patients you saw, and then count how many SPTs and scaling route plannings you did that week too. You get a feel for it and do that periodically. And you get an idea. That's just a way to get a temperature gauge.
And you can also run the procedure code report.
You could run your annual procedure code by provider. So you can do the whole practice would be all providers, but if you want to just know yours, you'd have to run it by your provider and you'd see how many prophies you did adult and child, how many perio maintenance, and how many scaling root plannings. So you have to run all your procedure codes for that. And typically it's easier for the whole practice than it is by provider, depending on the software.
Eric, are
Yeah,
you
Lauren.
are you doing that for Mount Pleasant or? Oh, okay.
I don't think so. We used to, I think, but
We knew, but I think we know it, but I,
yeah.
You can go in Dentrix and do the practice analysis report. And you look at production by procedure code and you take out by category, unchecked by category, as I recall.
Then it'll give you all the detailed procedures. Yeah.
Yeah, and select the date and the.
Yeah. Now that's lag numbers. What I'm showing you is something that's happened in the past, right? A lag number. You actually want lead measures. You want to be looking at it as close to today as possible. And so what is your year-to-date number constantly? So I'm a very competitive person. Now, Lauren, I have your numbers from Dr. Bryant's office. I have those numbers from a couple years ago. And, you look at those numbers, you go, okay, 42, 43%, that's phenomenal. That's where we want to be. That means I'm confident, I'm selling the condition, my patients are buying in, they're understanding what I'm talking about, and they're accepting the treatment, the recommendations I'm making. People are getting healthier. That's a win for the patient, right? The practice is healthier because of it as well. So it's a win-win-win all the way around. If your percentage is below that 35 number, I would want to look at your practice, your schedule, and figure out why is it lower. Now, Debbie, I would love it if you could talk about hygienists in the past that have been in your department where they had approval addiction, they didn't know how to sell a condition, whatever it was, and they did the super prophy over and over again. How did you help them get to a place where they could take an existing patient and convert them into a perio patient, even though they said, well, I've been coming here all along. Why all of a sudden do I have gum disease? How do you guys address that?
Well, it's with role playing and training. And I've had we just recently had 2 newbies out of school. So as team leader, it was kind of my job to kind of look in the background and see what they were doing for procedure and check x-rays and kind of coach them. And if I saw an issue, then I would present to them, tell me what your thoughts were. These are the numbers you got. Let's look at the x-rays. Give me the definition of a periodontal patient and now look at what you just told that patient. And I wouldn't, call them out on it in front of the patient, but we'd talk about it later.
Sure.
So that the next time the patient came in, then I would coach them on, this is where you want to take it.
Do you
If that
ever,
makes sense.
absolutely, do you ever calibrate with them where you're looking at pocket depths and you're measuring versus their measurements? Like, is there ever a difference in that?
There was in the beginning, sure.
What's the biggest thing? I'm just curious. This is me being curious here. What's the biggest thing you see as to why they're getting a different measurement than you're getting?
They're not getting into the call. It's probing angulation. And usually that's something that just comes with experience or it's not taught. I'm sure Julie and some of the others can attest to that. They have to put the probe in the right place to find what's going on. They have to look at the x-rays. They have to look at the tissue, the color. It's easy to just slide a probe around and say 1, 2, 3, 2, 2, 3.
Yeah.
Until you really look at it.
Yeah.
And what would you say as far, I hear this from doctors all the time. If you can't see the 3, it's not if you can't see that line, right?
It's a 4.
It's a 4. And some hygienists will go, oh, I'm not rounding up to a 4. I'm not doing that. Well, no, if you can't see that number, it is the next number, right?
Right.
I think that is absolutely huge for any hygienist for the veterans in the room to mentor them on that. And then recession, right? And then going back and doing recession and measuring it and getting an actual calculated number of pocket depth plus recession equals the total number that we're actually looking at. Is that correct?
Right.
Okay.
Furcation involvement.
Yep. And then
Looking at
bleeding.
X-rays.
Yep. Okay. So for me, planting the perio seed means I might be a new hygienist seeing a longstanding patient. I'm new to them. I really don't want to ruffle the feathers and walk in the first time I meet them that they're expecting a prophy and all of a sudden go, well, you have gum disease. We need to enroll you in scaling root planning and all the wrong stuff, right? And I've got to plant the perio seed. So I do that through the perio evaluation. I call out the numbers. So, Paula's my patient. I say, Paula, I'm going to use my ruler to measure how healthy your gums are.
Yep.
And I want to be able to share with you everything I see that deserves your attention as we go through this. Does that sound fair to you?
That sounds good.
Okay. If you hear numbers that are 4 or higher, that's a concern. Our goal, what we want to hear is 1, 2s, and 3s. That's a sign of health, and that's a shallow pocket depth. And absolutely no bleeding. If there's bleeding, that means there's active infection. Does that make sense?
It does.
And then I call out 3 numbers at a time till I get to midline, and then I go back checking for bleeding. Then I call it the tooth number, then the bleeding sites, and I move through. Okay.
So I put this up because the verbal skills are right here. Go to the very end of your manual, and it's like page 133 or 137, something like that. It's an addendum to your manual in the very back, and this is the clinical exam verbal skills, which we'll get into more tomorrow. And it starts right here. You're giving some word pictures. Your gums are like turtleneck sweaters are going to play part 3, like Eric was saying. And then when you actually get into calling out that number 333222, stop, something like that. So Eric, that's kind of where you were going. Thought I'd pull this up. So if they want to reference.
Those are implication questions right there, right?
Yeah.
You guys see them? Those are implication questions. Perfect. So once I'm doing that, they're overhearing what I'm saying. As they're overhearing, they're starting to self-diagnose. Now, that doesn't mean, again, that I'm going to recommend scaling root planning quadrant style at the end of this visit. I need to read the patient. And I might just be planning a perio seed. I might be getting them homework with a water pick or something, an electric toothbrush and a rinse and modular therapy and all this kind of stuff at home. And then we're going to reevaluate the next time you come in. If it's not improved, we're going to talk about steps that need to happen. Or if you don't want to risk waiting 6 months and having it get worse, we can take action now if you'd like. I give them an out because I don't want to pressure them into it. I just met them, but I'm prepping them for the next 6 months. Maybe we move into 3 months and we reevaluate in 3 months, right, Debbie? That's a gingivitis patient, let's say. Okay,
Yeah.
Now they're going to be a prophy. Here's another thing that I hear all the time from, hygienists at different levels, this term super prophy. And I think we have to be really careful because you can have a 60% perio practice, but the numbers show you're 20. And we get new patients come in and they leave going, well, that was the most painful cleaning I've ever had. Why is that happening, Debbie?
Because they're doing a prophy on a patient that has disease and it's going to hurt.
And they're going way too far, right? They're going too far and they're doing something beyond what has been accepted for case acceptance. So it's just so important for everybody to calibrate and be on the same page. And if it's a single hygienist practice, then the doctor and the hygienist need to calibrate and measure and evaluate and do the same patient. So in our practice, the hygienist went in, did everything, all 6 points, all bleeding, furcations, recession, mobility, everything, left the room. And then the next hygienist came in, did the same exact patient. They were like a pincushion. And then the doctor came in, did it too. And we had 3 different exams that we put in. And then we compared and saw, well, why did they see different? They went in, looked at it, and figured out where the difference was.
That's how we do it.
Got to be on the same page. You got to be on the same page. Otherwise, I'm going to have a different experience based upon which hygienist I see, especially if I rotate through hygienists in a practice. That makes sense, guys? So know your perio percentage. If it's not where it ought to be based upon industry standards, then we need to figure out why it's not. It could be a system. It could be perio calibrating. And it also could be approval addiction. It could be, I'm going to go do super prophies all day long because I don't want to tell my patients they have gum disease because they've been seeing me for 20 years now, and I'm afraid to tell them the bad news. But here's the deal.
I want to avoid the insurance problem.
Any of it, financial, what did you do to me? Why, you take the blame and ownership of their problem. Look, I don't have gum disease. Gum disease. I don't have heart disease right now. Knock on wood. I don't have high blood pressure, but I know as I get older, my risk for that increases. Right? The body doesn't hold together like it used to, and the same thing happens. I mean, patients will talk about how they don't get the flu for years and years and years, and all of a sudden one year they get the flu, right? And so patient might say to you, well, I didn't have gum disease at my last doctor's office. Why didn't they tell me about this? You've heard
And
that
we're gonna
before,
talk
right,
about
Debbie?
this
I've had,
Objection too.
Objections, yep.
Yeah.
we had a situation where we had a hygienist that left our practice even after she was fully trained. And then I started seeing her patients. And it was obvious that she hadn't been perio charting and her patients weren't sick. So just as a suggestion, when I did the charting and found out that, there was a problem, you ask them, have you never been told this before? No, everything's been great. And then my next comment is, I just went right over my head. Oh, shoot.
Yeah, that's okay. That's okay.
Oh, yeah. Well, what I'm seeing today, I know what it looked like the last
In the
time we were
present.
here, but what I'm seeing today indicates that it's changing. And
Yep.
then bring in, much like your blood pressure, it's going to
Yes.
be good for a long time. Your cholesterol levels, have you found that your cholesterol numbers have been going up?
Yeah.
Yep,
That's going
absolutely.
to happen regardless of how good you've been trying to maintain yourself. So this is what I'm seeing today kind of brings it to, it may not be the person that's doing it. It may be the situation for that day.
That's
I just-
really good.
I just thought of something that we need to add, or you could add in here is if the doctor's not going to come in and do an exam, you can bill out the D0180, the periodontal evaluation. I think a lot of hygiene departments miss that. And that is a hygienist exam. You get 2 exams a year covered, right? This is an insured patient, okay? So if the doctor's not going to come in, then you have an opportunity to charge that exam code. That should
Yep.
be on here as well. Yeah.
That's good. I think you're right, Eric, that people miss that. And
What
don't use
what
it.
was that exam code?
D0180. And it's when you do a full mouth periodontal evaluation, your doctor, and if your state allows for it, right, to see patients without the doctor present, you can charge that out without the doctor even being in the building. That has nothing to do with the doctor.
And do they get 2 of those a year in addition to regular exams?
Nope. So let's say they come in twice a year. One time they have a 0120, then the next time they can have a 0180.
Okay, thank you.
So I have the description. Now this is really small, guys, but I'll read it to you. So here's the D0180 that Eric is talking about here, and it's comprehensive periodontal evaluation, new or established patient.
I would
Is it-
not have my fee at $134 though. I'd have it at whatever my 0120 is.
Where is this?
Yeah.
Where this?
New
is this-
York.
Westbury, New York. Okay. Yeah. So the fee range goes up to $197. And the description says this procedure is indicated for patients showing signs or symptoms of periodontal disease and for patients with risk factors such as smoking or diabetes. It includes evaluation of periodontal conditions, probing and charting, evaluation and recording of the patient's dental and medical history and general health assessment. It may include the evaluation and recording of dental caries, missing or unerupted teeth, restorations, occlusal relationships, and oral cancer evaluation.
And if those things are happening, you're probably using a D0150 or a D0120. So I would separate those two. But I would have it match your 0120 code. It doesn't need to be twice the cost. They're looking at it more like it's a comp exam, really. But that will help. That will help if you're doing those and your doctor's not coming in on that day. Okay. All right. Awesome. All right.
Perio charting, can I ask, how often is everybody doing perio charting? Every visit, once a year?
Every visit.
Every visit.
That's great. That's awesome. So Debbie, what do you say to a hygienist that says she doesn't have time and can I just do within normal limits?
I have the luxury of having an assistant. I'd find out what's the reason that she doesn't have the time.
And
I
that,
tell
that's,
Initially,
that's where
'cause
you
that
can go
will-
go back to that page where we showed what you're doing, how many minutes. Yep.
Yeah, I just tell her not to do the cleaning because that's not important.
In some cases, it's not.
Got to get it started. Dr. Netzley, did you have a question or suggestion?
I have a big question. You talked about the new patient package. In our office, if a patient comes from another office, we don't charge for x-rays. Why would you charge when you get a new patient? So is this the same idea with the new patient package fee?
So what you're saying is you don't charge for x-rays if you have a new patient coming from another practice
That brings x-rays with
Correct.
them.
that brings x-rays with them? I keep the fee the same.
My question is, if you charge so much, they see it as a bad, thing for them. Wouldn't it be better to have a smaller fee
You
to
certainly
welcome
can.
them?
You certainly can. What we run into sometimes is the x-rays they brought from another practice are old or they're not very good.
Yes,
Um,
right.
or there was no pan, or maybe you have a cone beam and you want to take that. I mean, so I think you could bump up a little bit what the value of the x-rays they brought with them. They may be helpful, they may not be. I mean, that's kind of a, you know, what I try to avoid from like the new patient package, what we're trying to avoid is objection to taking x-rays. If you want to reduce the price because you're not going to take x-rays, that's okay. It's just we ran into really poor copies, like I said, or old ones that were way out of date or, something like that. So,
Well, my thing is, I have digital x-ray,
yeah,
and when they send me a paper copy,
yeah,
it's terrible.
terrible.
Yeah,
Yeah.
it's not going to work.
So I want it on my own computer.
Yeah. Yeah, you need to
No
have your own
charge.
set. Yeah, you need to have your own set and everything's under one charge. Now, when you get into the insurance part, Paula, it's like, well, my insurance isn't going to cover x-rays again because I just had them last year. There's ways around that.
Yeah.
All you need is 366 days.
Yeah.
If they're less
Right.
than a year, that's the only time you're going to run into a problem. Then you can talk about a pano. You could charge out a pano and take the x-rays at no charge if you want. So you still are creating value and getting production and billing something to insurance, et cetera. But listen, guys, when a new patient comes in, if you have a pano machine, we should be charging for 4 bite wings, first PA, additional PA, okay, 6 x-rays. That gets us close to the FMX code, but we don't bill an FMX code because I want the pano to be covered 32 days later or more. And I want them on an annual x-ray basis. I don't need to play the 3 to 5 year game. I can take as many x-rays as I want, but I'm only charging for 6, and those are covered every 366 days. Okay? The pano can be covered 32 days later, and I could put that on 3 to 5 year rotation.
Now, Eric, I want to
I-
talk. Go ahead, Dr. Netzley. Go ahead.
I'm trying to wrap my head around this new patient package fee versus the a la carte.
Yeah.
I would think you would want it less, and worry about my fees later
Yeah.
that
You
I'm going
want
to
the
be
new
making.
the package fee to be less than a la carte.
Right.
Dr. Netzley, are you getting echoes?
Always.
Remember, you can turn your microphone off on the phone so that you're not hearing yourself in 2 places. I think that's what you're running into. We'll work
Now,
on
how's that?
it. It's just up to
Oh.
you. Yeah. Better? Now you're not stuck in the matrix.
Okay.
Huh? All right. Good.
But The psychology here is why would you want to look like an expensive dentist and charge a whole bunch of money when I need this stuff anyway?
Yeah.
I'm looking for treatment down the way, and whatever patients are going to refer to me.
Yes,
Why do I need to, try to gather a few dollars in the beginning?
that's right.
You can set the a la carte fee to whatever you want. It doesn't have to be astronomical. So you can have a one package rate. It doesn't change up or down. I think Paula would agree with that. You can set the fee to whatever you're comfortable with. Like I said, a new patient is a loss leader anyway, right?
Right.
Yeah. So,
Yeah.
good question. Good question. Eric, can you pull up the tracker again? I want to talk about how many pans we should be taking a year. So the one with lots of patients or
Oh,
that,
okay.
that one's fine. That one's fine
Okay.
right there.
Sure.
1586 patients. So do you have a formula, Eric, that you use to help people know how many pans they should be taking a year?
No.
Okay, so this goes back to looking at your procedure code report. And the way I would look at it is, okay, you've got 1586 patients. So everybody, let's do the math. again.
788. Go ahead. Sorry.
What's a 788?
Oh, it's just halving that number, but you're gonna go ahead.
Yeah,
1586.
so I divide it by 2 visits a year, 2.5 for Perio. Obviously, they had a lot of Perio.
Yeah.
So it might be, so if we do the 2.5 visits a year, that comes down to 634 patients. Okay? So 634 patients. So I took your total number of appointments seen divided by 2.5. Okay? And then what we want to do is if you're taking them every 3 years, divide that number by 3, or if you're doing it every 5 years, you divide that number by 5 or divide by 4 if you're doing kind of a mix. So what do you think we should divide by? 4? Want to use
Okay.
4?
Sure.
Okay, so let's divide by 4. And we've got 158 pans. We're going to divide that by 4 years. Kind of a middle ground of 3 and 5. All right, so we go to our procedure code report and we look up the code for pan 0330 or whatever it is, and we want to count how many did we have. Okay, but we also want to add back in the new patients. Now, maybe the new patients were seen, like on this particular practice, how many new patients were seen in hygiene? Can you show that?
Number of new patients in hygiene.
Yeah. So they had 145.
They've seen them all on the doctor's side, 145.
Okay, so 145 doctor new patients. If they were comp exams, we need to add in another 145 to that number. Does that make sense?
Mm-hmm.
Okay, so if we add in an extra 145 new patients, how many is that? So 158 pans from hygiene, 145 on doctor's side, we need 303. So you can look at your procedure code report and see if you actually did that.
That's good.
That's a good way to measure, are we missing pans or not? I've done this with several teams and they're like, whoa, we had no idea. We felt like we were taking more pans, but in actuality, we were not. So there's an action item for you to count how many pans you're doing. Debbie, do y'all keep up with stuff like that or?
Yeah, we tend to do a traditional full set of x-rays, 16 PAs and a pan every 3 to 5 years.
Okay, do you actually go back and count how many you did?
Not really.
So you're doing something at no charge then, Debbie.
Doing something at no charge.
You're either doing the FMX or the pan at no charge if you're doing it the same visit.
Yeah, we do the 16 PAs and the pan, same visit.
So if you split them, you can charge for them.
Okay.
Obviously not every year. The pan won't be covered every year if you're playing the insurance, only if you're playing the insurance game. If you don't care and the patient's paying for
Yeah.
both out of pocket, that's fine too. But if you want them both to be covered, you just split them. So we do annual, the 16 x-rays, we take 16 or 18, but we charge for 6 because it's about the same rate, but I get it covered every year. And then I take the pan at the opposite hygiene visit every 3 years or 4 years, whatever it is, and then they're both covered that way. Yeah, so I don't ever write off a pan or an FMX. They're both covered.
Good idea.
If you're charging for both out of pocket and it's a cash pay patient, that's totally different. Do whatever you want. But if you're trying
Well,
to
we
pay
have the
insurance-
Denvantage.
Yeah, yeah. So if they're in the Denvantage and they're enrolled in it, you've already incorporated the fee, you're getting the fee anyway. Yeah.
Yeah,
All
That's
right.
right.
Awesome.
we have lots of that.
Yeah,
Okay.
yeah.
Oh, wait, I have a
Yeah, question, Lauren? Yeah.
So if we try, are FMX and PANs considered the same thing for insurance companies?
On frequency, yeah, it's one or the other for frequency. Yeah, FMX and a PAN is every 3 to 5 years. Yes.
Okay, thank you.
That's a
Yeah,
good
that's
question.
why if you stop using the FMX code and you just use 4 bite wings, first PA, additional PA, use that instead of FMX, then it doesn't matter. It's just a PAN competing with a PAN every 3 to 5 years. Yeah. Okay. Good.
Good stuff.
All right, Paula.
All right.
Do we want
Great.
to?
Discussion.
Yeah. Do we want to stop recording before we move into discussion
Yeah.
time? Okay.
Yep.